My name is Dr. Rahul Shah. I'm a consultant gastroenterologist here at Nanavati Hospital in Mumbai, and I'm going to talk to you about GERD induced chronic cough. So, GERD means gastroesophageal reflux disease, is a highly prevalent condition in clinical practice and is placing a growing burden on our healthcare systems globally. So, GERD has been traditionally linked to excess acid in the stomach, which refluxes back into the esophagus, causing damage to the esophageal lining. However, our understanding of what reflux is a bit poor, whether it's acid reflux, bile reflux, gas reflux. In that context, we have symptoms which often are classical heartburn, but they also cause symptoms as up as the pharynx, larynx, airways, and even the middle ear, causing potential harm. Population-based surveys that have been done show an increased risk of ENT and pulmonary symptoms in patients with reflux. And the odds ratio for laryngeal or pulmonary conditions in GERD ranges from 1.2 to 3, with the strongest association being nocturnal cough. People who have a cough when they lie down at night is a classical symptom of GERD. The proportion of chronic cough which comes to the gastrointestinal OPD or the pulmonary OPD ranges from 0 to 40%. So really high chances of a chronic cough being GERD. Establishing a causal link between GERD and chronic cough is challenging because often endoscopies are normal and we only rely on 24 pH testing and other complex impedance testing for us to be sure that this is truly acid reflux. Because reflux can be of three kinds: erosive reflux, where it's very easy to prove, non-erosive reflux, and hypersensitive esophagus, when GERD diagnosis becomes very challenging to a clinician. A study found a temporal association between reflux and cough, suggesting a potential self-perpetuating cycle. Chronic cough is a very common symptom. It affects between 9 to 33% of the people and is incredibly common in patients with a chronic cough. Can be associated with many things: asthma, post-nasal drip, environmental factors, drugs, etc. So, two theories have been proposed. One is a reflux theory, another one is a reflex theory for chronic cough. And this is very important in GERD. However, a past understanding has always been acid reflux. A current understanding is that there's something called pepsin. Pepsin is one of the key components of gastric reflux state, which transports from the stomach into the esophagus, gives rise to GERD symptoms. As we know, the gastric lumen typically reaches a pH of 1.6 to 3 and rarely ever falls below 1. And what we know about the gastric content is that it contains acid and pepsin. And the pepsin is meant to produce more harm than the acid itself. Pepsinogen originates from the same glands as the acid secreting parietal cells, and reflux contains pepsin regardless of its pH. So what pepsin does, it's in the reflux state, it disrupts the esophageal mucosal barrier in the esophagus by acting on the cell surface, while the bile acids, which is the bile reflux, often achieve causing damage by diffusing into the cells and causing damage within them. Even though we have effective acid suppressing drugs, a considerable number of patients with chronic cough attributed to GERD do not respond to standard therapy, and that's when trouble starts. So PPIs are of course highly effective in GERD related heartburn and regurgitation, supported by numerous clinical trials and global experience. However, the effectiveness diminishes when symptoms originate from other organs, other reflux states, which means that pepsin may play a huge part causing damage to the esophagus. So while of course antacids remain a mainstay in treating extraesophageal and esophageal reflux, profound acid suppression may not be enough to achieve GERD treatment in many patients. So antacids alone or in combinations with PPIs show better clinical outcomes over conventional therapies of GERD and chronic cough. What do antacids do? They neutralize the stomach acid, they raise the pH and reduce the acid concentration of the gastric content by 100-fold. Clinical studies show that antacids with specific ingredients as sodium bicarbonate, calcium carbonate, aluminum hydroxide, or magnesium hydroxide carbonate provide substantial relief to patients with GERD and patients with chronic cough. Megaldrate, a hydroxy magnesium aluminate complex, along with simethicone, effectively reduces acidity by acid neutralization and offers several other properties. Inhibits pepsin, it helps to bind the bile acids, lecithin. It also protects the gastric mucosa and also optimizes the pH from 1.6 up to pH of 4, and hence playing a crucial role in GERD and chronic cough patients. In conclusion, I think antacids play a crucial role in managing chronic cough with GERD, primarily by neutralizing the excess stomach acid, elevating the pH, also reducing the acid levels by reducing the pepsin content in the stomach refluxate, and in more severe cases, PPI may be recommended for higher doses. However, adding in an antacid combination is incredibly valuable to patients with GERD-related chronic cough, and this really improves the quality of life for patients. Many thanks for listening to my talk.